Good afternoon, everyone, and welcome to another edition of Friends Talking. This afternoon, we have the privilege of welcoming a wider audience of friends who will be joining in our conversation. Uh, Friends Talking, for those of you who are new, is a group of Christian Seventh day Adventist brothers that came together earlier in the pandemic and started meeting every Saturday afternoon.
At the organic
This month, this month marks our 1 year anniversary. The group provides a safe space where men can share openly, confidentially, and without judgment, and where the freedom of thought and expression, the freedom of thought and thought of expression is honored and respected. As one of our members recently said, we don't always agree. Uh, However, the friendship remains strong. Each week, we have guests that stimulates the conversation by sharing their knowledge and ideas with us. We have an average attendance of 20 men each week, joining from the UK, throughout the Caribbean, and the United States. The group not only meets to converse, we have also engaged in giving back to the community by sponsoring the education of a student at NCU, Northern Caribbean University in Jamaica. Today's presentation represents one act of giving back to the community, as our guests will be sharing information that we could not keep to ourselves. It is my privilege to welcome this wider audience to Friends Talking. We want to express our gratitude to the Mount Sinai Seventh-day Adventist Church in Orlando, Florida, and to the Southeastern Conference for collaborating with us on the use of their social media platforms to bring this program to you. On behalf of Friends Talking, we welcome you and look forward to your participation via the group chat in YouTube and Facebook. Welcome. Gentlemen, it is good to have you all here. And at this time, I'm going to invite one of our member, Professor Michael Allen, to pray for us as we begin.
Let us pray. Father, we thank you for the privilege of gathering together via technology on another Sabbath. Thank you for friends. Thank you for your friendship for us, a friendship so strong that you were willing to die to provide an abundant life for us. We accept it by faith, and we ask you to forgive us of the times when we have failed you, friends. Thank you for this forum that we can share this week with a wider audience. Thank you for our guest, Dr. David Williams, and for what you have invested in him in knowledge and experience that he will share with us. And as we consider the challenges that face us as a society and as a world, where public health challenges and social inequalities cause further problems of disease and lack of longevity, we ask that you will provide him with the wisdom and the clarity to teach us today and to give us pointers and ways in which we can intervene as Christians to make our communities safer, healthier, and where life can flourish even in the midst of difficulty. So we commit this afternoon's program to you. We thank you for the leadership, Brother Marcel and others who have facilitated this forum, and for the guests who come from week to week. May this week's conversation be edifying, helpful, and practical. These things we ask in Jesus' name. Amen.
Amen. We have with us this afternoon Dr. Derek Moffat, the pastor of Mount Sinai Seventh-day Adventist Church. And at this time, we invite him to bring greetings to us from the church.
I appreciate you, Brother Marcel. Thank you so very much for allowing me to be a part of this august group of men and all those who are joining us. We just want to say to the entire group, we praise the living God for what you are doing. And a special welcome to Dr. Williams for joining us and sharing the things that God is putting on his heart to share with us this afternoon. So I just thank you all for being a part of this wonderful group. And thank you, Brother Marcel, for allowing me to be a part of the group as well.
Thank you, sir. Thank you. At this time, Dr. McCallum, would you kindly introduce our special guest for today, please?
Thank you. Thank you, Marcel. Um, Several years ago, my wife attended a conference in San Francisco, and one of the speakers there was Dr. David Williams. And after she returned from this conference, she was telling her supervisor, a tenured professor at the University of Miami. My wife happens to be a clinical psychologist, and she was telling her about the people she met, some of the students, and she mentioned that she met Dr. David Williams there, and actually they went out and ate supper that evening together. And the professor's response was, David Williams? You know David Williams? David Williams? And she said, yes, yes, yes. And so let me tell you a little bit about David Williams. You can read his entire bio if you like. Go to the Harvard site, but I will give you the Adventist version, okay? Dr. David Williams is the Norman Professor of Public Health and chair of the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health, and the professor of African and African American Studies at Harvard University. His prior faculty appointments were at Yale University and the University of Michigan. Now, he's a product of Christian education. He received his elementary and high school education at the Seventh-day Adventist schools in St. Lucia, Castries, St. Lucia, and that's where I met him. As a young boy, my father was pastoring there, and we met at that time. The entire Williams family, they're brilliant. He has a sister, Ruth, who's on the faculty of Southern University, Ruth Williams Morris. And they're known for being very brilliant and very strong supporters of the church and the school. And one of the things that I realized about it, thinking about this today, both of us started in one-room schoolhouses. The church building was the school, and yet we were successful. And thinking about it, it's not what's in the building, it's really what's in the people who are putting what they're putting into you. So it's the teachers, the family members, and those who want us to learn, we will learn. And so for those of you who are thinking about Christian education for your kids, I support it 110%. He was also a graduate of the University of Southern California, Andrews University, where we also became reacquainted, and Loma Linda University. Received his PhD in sociology from the University of Michigan. Dr. Williams has been invited to be a keynote speaker in many scientific conferences, Europe, Africa, Australia, the Middle East, South America, and across the US. He's the author of over 500 scientific papers. That's hard to imagine, but that somebody could do that, but he has, one of our own. His research has enhanced our understanding of the ways in which social factors like stress, race, economic status, racism, health behavior, and religious involvement affect our health. Dr. Williams has been involved in the development of health policy at the national level. I was aware that he was on Carter's advisory committee when they were trying to Hillary was had the committee where they're trying to get health insurance for all. But I was not aware that he was on also some of the Republican administrations in trying to counsel them. His research has been featured at the national in the national media, and he has a TED Talk, which you should go and listen to if you haven't. He was the second Adventist elected to the National Academy of Medicine in 2001, and the first Seventh-day Adventist elected to the National Academy of Sciences in 2019. He has been ranked as the most cited Black scholar in the social sciences worldwide, and as one of the world's most influential scientific minds. Dr. Williams serves on the board of Oakwood University, and I recall his graduation address in 2013. It was very powerful, very moving. And if you have an opportunity, go back and listen to that at sometime after, if you will be moved by it. He's also on the Loma Linda board also. He's an associate director of the health ministries of the General Conference of Seventh-day Adventists. He's married to Opal Reed. She is the daughter of a centurion. Those are pastors who baptized more than 100 in a crusade. Well known in Jamaica and in England, Dr. Silburn Reed. And they are parents of 3 daughters. One of the things I found about Dr. Williams' presentations is that they always stimulate my mind. They always make me a little unsettled in some of the things he says, because I question some of it, but it is what it is. And I always feel enlightened after I've listened to him. And if you have not heard him before, then you're in for a treat. If you have heard him before, then I know you're waiting with anticipation. So I just want to say thank you to Dr. David Williams, my friend, for agreeing to be with us today. And listeners, I present to you Dr. David Williams, the David Williams.
Thank you so much, Lenny. This is what you have when you have a good friend introducing you. You never know what to expect. But it's an honor and privilege to be here. Lenny is correct. We go way back to elementary school. And I also would say one other thing. It's his father, Pastor McCullough, the late Pastor McCullough. Without Pastor McCullough, I might not have been here. Because at the time in St. Lucia, yes, we had a one-room elementary school, but the Catholic schools were funded by the government, but run by the Catholic Church, and the entrance exam was on Sabbath, no exceptions. And it was under Pastor McCullough's leadership that the churches in St. Lucia banded together and said, we'll raise money to start a high school. And that is a high school I graduated from. Things are different now. There are lots of government high schools, but in those days, that St. Lucia as the Academy made a huge difference for Adventist young people to be able to go to high school. And it was Lenny's dad, my pastor at the time, who started the ball rolling of energizing the entire church community to do it. And we need to do the same. That kind of commitment that was demonstrated back then is wonderful. I have a lot of territory to cover today. I'm going to jump right into my talk, but just thanks to all of you who are taking time out of your Sabbath-lay activities to join us today, and hopefully you will be blessed by the presentation. I'm going to share my screen so that you can see what I will be covering, The topic is, as advertised, today's health and social problems, what God is calling us to do. I'm going to begin with where most people are today in the US when we think of COVID-19. We think of the death rates, and we hear all the time that it has had a devastating negative impact on communities of color. So here is the data. Of 520,000 deaths. This was through March 2. And what are listed on this chart is the odds ratios, so the risk of dying for other populations compared to the white population. So the white population is 1, and you can see the death rate of the indigenous population in the US is 2.2 times higher for the Latino population, 2.4 times higher for the Black population, twice as high for the Pacific Islander population, 2.6 times higher. The Asian population is similar to that of the white population. A little moment of education here, because a lot of people I have run into think that because the death rate is higher for Latinos and African Americans, for example, that whites are not at risk. and which is not exactly the case. The risk of death is higher, but if we look at a total number of people who have died, almost 300,000 of people who have died have been white, compared to 89,000, almost 90,000 Latinos and 73,000 African Americans. So as you look at the numbers, you can see that this has had a devastating impact on all populations, although the risk of death, but not the total number of people who have died, is higher for populations of color. I want to say several things about the death rates from COVID-19. One, what we see from COVID-19, we see for virtually every major cause of death. And I'm just going to show you one in the interest of time: infant mortality in the United States. Infant mortality refers to the chances of a baby dying before its first birthday. And you can see that the infant mortality rate for the Black population is more than twice that of the white population, and the American Indian population also has an elevated risk. So what we see for COVID-19, we see for a broad range of health conditions. The second point I want to make is that we talk a lot about racial disparities in health in the United States. Racial disparities in health is a global problem. In all racialized societies, whether they're in Latin America, in New Zealand, Australia, in South Africa, in Europe, we find the same pattern where there is data. I'm going to show you, in the interest of time, just data from the United Kingdom. And here are the death rates, age adjusted, similar to what I showed you for the US, for the Black men in the United Kingdom, mainly men of African, immigrants from Africa, or children of immigrants from Africa, immigrants from the Caribbean, or children of immigrants, children, grandchildren from the immigrants of the Caribbean. And you can see there, the gap is even wider than the United States. Black men in the UK are 4.2 times more likely to die from COVID-19 compared to whites. For Bangladeshi and Pakistani males, which is another very disadvantaged group in the UK, it's 3.6 times higher for men. For Indians, it's 2.4 times higher. And if you look at the data for women, you see a similar pattern. Black women in the UK, 4.3 times more likely to die. Bangladeshi, Pakistani, 3.4, 2.7. It's a global problem. In the interest of time, I'm not going to show you data from other countries, but the racial disparities in health is a global problem. The US has more data. We more routinely collect data. We more routinely report data, but the patterns are very similar in other countries around the world. I also want to talk about how dramatic the impact of COVID-19 is on the overall health in the United States. This is a report that came out recently from the federal government showing the life expectancy for Americans by race in 2019 compared to the life expectancy in the first 6 months of 2020. We don't have data for the entire year yet analyzed, but the first 6 months. And what you can see for the Hispanic, for the white, and for the Black population, COVID-19 has led to an absolute decline in life expectancy from 1 year to the next. Here is the data broken down by race and gender. So the life expectancy for Black men in America has declined by 3 years from the 2019 data in 2020. For Hispanic males by 2.4 years, for Black females 2.3 years, for Hispanic females 1.1 years. For white males, it's 1/10 of a year, and for white females, it's 7/10 of a year. It is striking in the last 50 years to see declines of life expectancy for any population group on the order of 3 years or 2 years. That is virtually unheard of. We sometimes see declines, but they're usually 2/10 of a year, 3/10 of a year, nothing of this kind of massive scale that we are seeing in terms of the overall population. So the big question is, what drives these large racial inequities in health? Why do we see these patterns? The first thing I would suggest is there are large inequities in health by socioeconomic status. When I use the term socioeconomic status, I'm talking about income, education, occupational status, wealth. Those are indicators of socioeconomic status. And what we know is that socioeconomic status is the single biggest predictor of variations in health in the world. In virtually every country of the world, people who are higher in income, education, occupational status, on average, have better health than those who are worse off. And when we talk about race and ethnicity in almost every country of the world, race and ethnicity is correlated with economic status. So here is data for the US. National data for 2018, the median household income for different groups by race. I'm going to translate this data in a way you can't miss the point. I'm standardizing on the dollar of $1 as the household income of white households. For every dollar of household income white households receive, Asian households receive $1.23. 2 points to keep in mind. Almost 70% of Asians in the United States are immigrants, and they have come to the United States with high levels of education. They have markedly higher levels of education than the white population, for example. Secondly, and importantly, the Asian population in the United States has more persons contributing to household income on average. So if we had a per capita or per person measure of household income, whites would have the highest levels. But let's look at the historically disadvantaged groups. For every dollar of household income white households received in the year 2018, Latino households received 73 cents, and Black and Native American households received 59 cents. Do you know what is stunning about the 59 cents figure for Blacks? That is identical to the racial gap in income in 1978. You heard me correct, I didn't misspeak. In 1978, the peak year of the narrowing of the Black-white gap as a result of the civil rights policies of the 60s and 70s and the war on poverty, the anti-poverty policies of the 60s and 70s, the gap had been narrowed to 59 cents. And in 2018, it is still 59 cents. Most of my students think we have made, and most Americans think we have made a lot more progress in the US than that. The gap has not been stable at 59 cents. Throughout the decade of the 1980s, it fell from the 59 cent figure, and it wasn't until 1994 it got back up to 59 cents, and it's a penny up and down from that since then. So what I'm saying is, when we say race, on average, there are exceptions, there are millionaire Blacks, but on average, we are talking about marked differences in economic status. One other indicator is poverty rate, the rate of poverty. Poverty was defined by the United States government in 2018 as a household income of about $24,000 for a family of 4. If the family is less than 4, it falls from that level. And using the federal poverty level, you could see 1 in 5 Blacks in 2018 were poor, compared to 1 in 10 Asians, compared to 1 in 4 American Indians have the highest rate of poverty, almost 1 in 5 Latinos, compared to about 8% of whites. Again, people confuse the rate of poverty with the number of poor people, so I'm going to show you that as well. This is the number of people who were poor in 2018 in terms of millions of people. So the largest group of poor people in America are whites. There were 15.7 million poor white people, about 10.5 million poor Latinos, almost 9 million poor Black people, 2 million poor Asians, and 700,000 poor American Indians. Okay, so we have looked at the fact that when we say race ethnicity in the United States, we are talking about categories that are patterned by economic status. The data I have showed you, which focus only on income, dramatically understates the racial gap in economic status. And what I mean by that, income captures the flow of resources into the household. It's your wages, it's your salary. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth, which is your assets, your savings, your financial investments, your home equity. And the latest Federal Reserve Board data on racial differences in wealth shows for every dollar of wealth that white households have, Black households have 10 pennies, and Latino households have 12 pennies. So there are strikingly large racial differences in wealth in the United States. When my career started, most researchers thought that the racial differences in health were simply a function of the racial differences in income and education. We now know that life is more complicated, and I'm going to give you one example of national data to illustrate that. So life expectancy at age 25. Life expectancy refers to how long will the average person who's 25 years old live in the United States? How many additional years? And I'll show you the data for Blacks and for whites. The average white person at age 25 will live 5 years longer than the average Black person. But if we look at the data within the white population by education, the same is true for income. I'll show you the education data in the interest of time. A white person with a college degree lives 6.4 years longer than a white person who has not finished high school. So the gap within whites by education and by income is bigger than the Black-white gap. The same is true within African Americans. A college-educated African American is going to live 5.3 years longer than one who has not finished high school. Again, within race, economic status, education, income predicts dramatic variations. At the same time, there is something else about race that matters. So if we look among high school dropouts, white high school dropouts in the US live 3.1 years longer than Black high school dropouts, and that gap widens as education increases. So whites with a college degree live 4.2 years longer than African Americans with a college degree. And here is a stunning statistic, and remember this is national data for the United States. The best off Blacks in terms of education, in terms of their health, they have lower life expectancy than whites who have a college degree. They have lower life expectancy than whites with some college. College-educated Blacks in America have lower life expectancy than whites who have finished high school. So what do these data tell us? There's something about your income and education that matters for your health regardless of your race. But there's something else about race that matters profoundly even after you've taken income and education into account. And so researchers have been asking for the last 25, 30 years, what else is it about race? Could racism be a contributor to help us understand these racial disparities in health? When I use the term racism, I am not talking primarily about the beliefs and behavior of individuals. Racism is a societal system. Yes, it categorizes and ranks, devalues and disempowers, differentially allocates opportunities and resources to groups regarded as superior, compared to those regarded as inferior. It can lead to negative attitudes and beliefs, prejudice and stereotypes. It can lead to differential treatment by individuals and social institutions. So that's racism. And I want to argue today, and I'll show you evidence, that racism exists in our society through multiple mechanisms. First, as part of society, it shapes and is reshaped by larger political, legal, economic, religious, cultural forces, and historical events. But there are three mechanisms of racism by which it matters profoundly for health, but also for income and education, employment and housing and so on. We'll talk about institutional or structural racism. We'll talk about individual discrimination. We'll talk about cultural racism, and I want to give you an example of each of them quickly. So let's distinguish between the individual and the institutional or systemic or structural discrimination. Let me give you an example. This is national data for the United States. In the 2012 presidential election, how long did Americans stand in line at a precinct waiting to vote? On average, Black people waited 23 minutes, white people waited 12 minutes, and you can see the difference for other groups. Importantly, none of that reflected the behavior of local precinct workers. Instead, it reflected where you voted and what was the budgetary allocation for the supporting the voting process in that geographic area. What was the size of the facility used? What was the number of precinct workers hired? So it's all bureaucratic administrative procedures that led to dramatic differences in outcome where all the precinct workers treated everybody with dignity. So there was no bad behavior or discrimination on the part of precinct workers. And that's what we call institutional or systemic discrimination. It's discrimination that's embedded in the way society and organizations actually function on a day-to-day basis. So I want to talk about one in my TED Talk. I call it the secret source that drives racial inequality in America that nobody is talking about. It's residential segregation, a striking legacy of racism. John Sell was a British born historian. He was a professor at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He showed the framers of apartheid in South Africa got the idea of apartheid from America. They looked across the Atlantic in the early 20th century and they saw how well segregation was working in America and they said, brilliant, we can implement that in South Africa. Importantly, Sell argues that residential segregation by race was one of the single most successful domestic policies of the 20th century in the United States. And you're saying, what does segregation have to do with anything? Well, think of segregation as a toxic emission produced by an industrial plant, racism. Like carbon monoxide is often imperceptible, but once segregation enters a community, valuable resources disappear. Things like good schools, like safe playgrounds, like good jobs, like healthy air and safe housing and good transportation systems and even access to high quality medical care. All of these things vary in the United States by where you live. You want data? I'll share with you 3 studies, 4, that will give you overwhelming scientific evidence. These are 2 of my colleagues at Harvard, William Julius Wilson, Robert Sampson, 2 of America's most eminent sociologists. They studied 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to those of blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. And if you look carefully, that was a 1995 publication, and you say, well, have things changed? So I want to talk about the work of another colleague, was a colleague of mine at Harvard. She's now at Brandeis, Dr. Dolores Acevedo Garcia. She has created an amazing resource. It's called, it's the diversitydatakids.org. On that website, you can find it. She's looked at 29 different indicators of access to opportunity for kids. And she has ranked every census tract and every county in the United States by those indicators, 29. Things like the quality of elementary schools, the high school graduation rate, the median household income, the home ownership rate, the environmental quality of the air, the water, the soil pollution, exposure to hazardous waste, and resources for health, such as access to healthy food and green space and safe places to exercise. There are 29 indicators. I'm just giving you an example of them. What she finds is that if you look at 100 largest metropolitan areas in the United States, 2/3 of all Black children in America are living in very low or low opportunity neighborhoods. That's also true of 58% of Latino kids and 53% of Native American kids, but it's true for only about 1 in 5 white and Asian kids. If you look at who lives in high and very high opportunity neighborhoods, almost 2/3 of all white children and almost 2/3 of all Asian children live in high or very high opportunity neighborhoods compared to 1 in 5 Black and Latino kids. So opportunity at the neighborhood level matters profoundly. More evidence. The racial ethnic differences in income and education that I showed you the income data didn't just happen. So let me show you another study. This one, national data for the United States. This is Dr. David Cutler, one of the country's leading economists, also happens to be at Harvard. He published this paper using a national sample of Blacks and whites and using fancy econometric models. He's able to show statistically, if you could eliminate residential segregation in America, you would completely erase black-white differences in income, black-white differences in education, and black-white differences in unemployment, and reduced black-white differences in single motherhood by 2/3. All of those striking differences are driven by opportunity at the neighborhood level. Another way to say this, why are there these racial differences in income, education, occupational status, and wealth? Because blacks and whites live in neighborhoods that differ in access to opportunity. One more study happens to be another Harvard economist, Raj Chetty. He has done an amazing study. He also has a website called the Opportunity Atlas that has more data here than I will show you. What he has done, he has looked at data, got the US Census to give him access to census data for every year, 1989 to 2015. And he's asked a simple question. Let me look at blacks and whites that begin life at the same household income. How are their children doing in the next generation? And he finds that in 99% of census tracts are a big neighborhood area, black boys earn less than white boys even when they started out in life in households that had the same level of income. Why? Because they live in neighborhoods that differ in access to opportunity. If they live in neighborhoods with good opportunity, they do just as well. But that's only true of 1% of black boys in America. So what am I saying? I'm saying that the racial inequities in economic status that we see that are consequential for life and consequential for health do not reflect a broken system. In fact, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism, and many of which are not linked to anything that individuals do. It's how the policies, and that's what people mean when they talk about structural racism, is policies that have been in place for more than a century and continue to work and do what they were intended to do. Importantly, these inequities are not accidents or acts of God. They, in fact, instead reflect a social system functioning the way it was intended to do. How does all of this matter? It means that when you are lower in economic status, even though we're all in the same storm of the pandemic, we are in different boats. And some boats are better able to deal with the storm than others. And what research shows is that when you are of lower economic status and you live in disadvantaged, segregated neighborhoods, you have higher levels of exposure to economic stress, to psychosocial stress, to discrimination, and to physical and chemical stresses. One example linked to COVID-19, these are some of my colleagues at Harvard, showed that if you live in a neighborhood with high air pollution and you get COVID-19, it's much more likely to be severe. And if you get it, you're much more likely to die, just linked to exposure to COVID-19 plus air pollution. And one of the areas of work that I have done is the stress of discrimination. Martin Luther King suggested that discrimination is not something that's, innocuous. He said it's a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as a truth in the society dominating them. So one of the things I did was to develop a measure to capture discrimination. I actually developed several measures. I'm only going to talk about one of them. It's called the Everyday Discrimination Scale. Today, it's the most widely used measure to study discrimination worldwide. As of today, there are more than 400 peer-reviewed scientific papers looking at just the Everyday Discrimination Scale and looking at health outcomes. And what we have found has even surprised me, because what the scale captures are not big things, but just little indignities. Being treated with less courtesy and respect than others, receiving poorer service than others at restaurants or stores, people acting as if they think you are not smart, or if they're afraid of you, or they think you are dishonest, or they're better than you are. Let me just illustrate some of the findings, and this is just a sample. But every health outcome listed here, studies have documented higher levels of everyday discrimination leads to earlier onset of metabolic syndrome, earlier onset of cardiovascular disease, earlier onset of breast cancer, earlier onset of type 2 diabetes, leads to greater use of substances to deal with the stress, leads to higher levels of coronary artery calcification, intima media thickness, that's a measure of subclinical heart disease, of abdominal fat, of heart rate variation, of AFib, higher levels of blood pressure, poorer sleep, higher levels of inflammation, of cortisol, a stress hormone, lower telomere length, that's greater accelerated aging, higher levels of obesity. Discrimination leads people to engage in behaviors that lead higher levels of obesity, lower levels of engagement with the healthcare system, and higher mental health problems. These are just a sampling of the outcomes that have been documented that is linked to the stress of discrimination. And what researchers have documented, they're using different terms. Some use the term accelerated aging, some leave the term premature aging, some use the term biological weathering. What they are describing is that Black people in America are literally aging biologically more rapidly than whites. So at the same chronological age, two people age 50, Black and white, the Black person in some studies is about 7.5 years older physiologically, or 10 years older in some studies. The way to think about this is your age captures not only how long you've lived, but if you live in a bad environment, your age is also capturing how long you've been exposed to bad environmental conditions and how physiologically compromised you have become as a result of such exposures. So I'll give you one example of the consequence of this. This is from CDC. It shows, and let's just look at age 50 to 64. This is national data for the United States, people age 50 to 64, 61% of Black people have high blood pressure compared to 41% of whites. And we see this earlier onset of disease at every age for all of the major chronic diseases. I'm only showing you blood pressure in the interest of time. Remember those simple items on the everyday discrimination scale and how they affect health? Here is a study from the UK that should be sobering for us. It's a study of horses, okay? Not that intelligent, right? But what this study found is that horses had physiological reactions that could be measured to the facial expression that people had. And if someone's face was angry, they saw increases in heart rate and other stress-related physiological changes in the horse. The same is true of people. And I want to bring this home to us. If we read in the book Christ Subject Lessons, we are told that every person is surrounded by an atmosphere. It could be charged with the life-giving power of faith, courage, and hope, and sweet with the fragrance of love, or it may be heavy and chill with the gloom of discontent and selfishness, or poisonous with the deadly taint of cherished sin. And look at what it says. By the atmosphere surrounding us, every person with whom we come in contact is consciously or unconsciously affected. Now, we're in the pandemic, we're not having contact with a whole lot of people, but what that says to me is that on a weekly basis, everybody who enters my presence is either pushed a little closer towards heaven or a little closer towards hell as a result of being in my presence. People are affected by us just by being in our presence, far less by how we treat them on a day-to-day basis and whether we treat them with the dignity and respect that they deserve. Let me quickly touch on cultural racism because I want to talk about the solutions. You know, there are negative stereotypes about race and that are deeply embedded in our culture. These stereotypes come from the media, come from our literature, come from, just the way we function, the beliefs that we have. A group of scientists have put together a database of American culture. It's 10 million words. The books, magazine, articles the average American would read. What's brilliant about this, if you've got American culture in a database, you can say in American culture, when the word black appears, what adjective most commonly co-occurs with black? It's poor, then violent, then religious, then lazy, then cheerful, then dangerous. When white occurs, wealthy, progressive, conventional, stubborn, successful, educated. When female occurs, distant, warm, gentle, passive. When male occurs, dominant, leader, logical, strong. If you were raised in this society, these are the associations you have seen. Here are the 10 most common stereotypes and the adjectives going with them for blacks and whites. And you can see the predominance of negative stereotypes for blacks. What this means is that when a police officer looks at a black male and believes him to be violent and more dangerous than the situation actually is, we may not necessarily be dealing with a bad cop. We may be dealing with a normal American who is acting and what is deeply embedded in his subconscious because he was raised in the culture of this society. And these biases shape how all of us function. This is a report published in 2003 by the National Academy of Medicine called Unequal Treatment. Congress had asked them to answer a simple question. When Black people and other minorities go into healthcare context in America, does your race determine the quality of care that you get? And what the study found was that across virtually every therapeutic intervention, from the most simple to the most complicated, Blacks and other minorities receive poorer quality care than whites. I'll give you one quick example. Dr. Todd was an emergency room physician at UCLA. He asked a simple question. When a patient comes to the UCLA emergency room with a long bone fracture, that's medical speak for a broken bone in the arm or legs, does the patient's ethnicity determine whether or not the patient gets pain medication? 55% of Hispanic patients got no pain medication compared to 26% of whites. He statistically adjusted for everything else. The single biggest predictor of a patient getting pain medication was the patient being Hispanic. He went to Emory University in Atlanta, repeated the same study looking at Blacks and whites and found the same thing. A Black person with a broken bone in the arm or leg goes to the emergency department, less likely to get pain medication. Folks, don't focus on pain medication. There are lots of studies of pain, but there were more studies of the treatment of individuals for cardiovascular disease than any other. And this pattern was documented in every area of medicine. I just published a review paper earlier this year that shows the pattern still persists in America today. It has actually gotten worse for some health outcomes. I'll give you one study from Florida, published last year. A study of 1.8 million hospital births in Florida between 1992 and 2015. When cared for by white doctors, Black babies born in the state of Florida are 3 times more likely to die in the hospital than white babies. The disparity is cut in half when Black babies are cared for by a Black doctor. Now, this study just shows the patterns. It doesn't give us the explanation, but it tells us something is terribly wrong. I've talked about the problems. What on earth can we do about them? Well, we need to eliminate inequities in the receipt of high quality care, like I've just talked about. And there's actually drugs that could solve the problem of the bias of providers. This is really true. This is a high quality study from the UK, showed 1 dose of a beta blocker eliminated implicit bias among healthcare providers for the next 2 hours. The only problem with this, we cannot medicate the entire world's population indefinitely to solve the problem of implicit bias. This is an important study though. It shows that this implicit bias, this unconscious discrimination, is something that is a fundamental physiological process in your brain that can be intervened on with a pharmacologic agent. There are political leaders who have said implicit bias is fake news. It's all made up. It's not true. No, it's real. We can actually intervene on it in the brain with pharmacology. Luckily, there are a number of strategies psychologists have identified. I only talk about one of them in the interest of time: individuation. All of us process all the complex cognitive information we face every day through social categorization. We put things into categories. That's normal, that's natural. The only problem with that is every society, every culture, every community has in-groups and out-groups. Groups that are viewed positively and groups that are viewed negatively. And what happens is when you meet somebody, in 1/3 of the time it takes to blink your eye, you will note the social categories to which they belong. And if you have negative stereotypes about those categories, you will treat that person differently. It's automatic, it's unconscious, without even being aware of it. I like to tell my students I think of myself as a prejudiced person. And I say I think of myself as a prejudiced person because I think of myself as I would like to think of myself as a normal human being. And if you're a normal human being, you're probably prejudiced. I didn't say you're racially prejudiced, because this is not about race. It's how we process information. Because you may not have racial prejudice, but what are the deeply embedded negative stereotypes you have based on your socialization about women, about gay people, about fat people, about poor people, about old people? You get the point? It's the social categorization. These processes also occur. Individuation says, when I meet someone, I'll resist the temptation, my natural tendency to treat them on the basis of their social category, and I'll try to understand this person as an individual. And there's studies that show that people can be trained and to use these psychological strategies, and they are effective in reducing implicit bias. What else do we need to do? We clearly need to diversify the workforce to meet the needs of all patients, as the data clearly indicates. I want to show you a randomized controlled trial. This is a high quality scientific study of 1,300 Black men in Northern California. They were recruited from barbershops and flea markets, sent to a Saturday clinic at a nearby medical center. What they did, randomly, half of them were served by a white physician, half of them were served by a Black physician. What they found, men who saw a Black doctor, these are Black men who saw a Black doctor, were 29% more likely to talk about other health problems, 47% more likely to do the screening for diabetes, 56% more likely to get a flu vaccine, 72% more likely to do screening for cholesterol. So all their engagement with the healthcare center was a whole lot better if they were seen by someone with whom they could identify. The good news is there's some evidence to indicate that we can eliminate racial disparities in care if providers are high on what we call cultural competence. And there's a lot of stuff happening under the rubric of cultural competence that's not effective. But I want to show you from this study, they rated providers on an indicator of 20-item scale on cultural competence. I'll show you some of the items. It was physicians who were high in cultural competence were those who agreed that family and friends were as important to health as doctors, that social history contributed to how they care for their patients, that they were familiar with the lay beliefs their patients had, which means they had to ask them about it, that they asked their patients about alternative therapies they use, they found out what their patients thought was the cause of their illness, they involved their patients in decisions about their healthcare. So you see a level of dignity, respect, collaboration, working together, talking, listening to their patients. And among those providers who scored high on these values, there was no racial disparities in health. It's just that that isn't true of most healthcare providers in the United States. What else do we need to do? We need to do what I call create communities of opportunity. If you listen carefully to me, the problem deeply embedded in American society is where you live and the opportunities, the access to opportunities you have. So how can we neutralize these things? A lot of things we need to do, which I can't elaborate on, but we can come back to them in the question. We need to invest in early childhood. There's high quality evidence that indicates if we provide for children in the first 5 years of life, high quality environments we not only ensure they're more academically and vocationally and professionally successful, they literally have better health, lower risk of heart disease in their 30s based on a huge metabolic profile based on what we did for them birth through 5. We need to reduce early childhood poverty. We need to enhance income and employment opportunities for youth and adults. We need to improve neighborhood and housing conditions. We need to provide care that addresses the social context, and we need to build for policies that accomplish these things. So all of these are key things to be done. Let me give examples. I want to bring it home to an Adventist community. Here is an example from Loma Linda University. Loma Linda University sits in Loma Linda, California, 2 miles away from the city of San Bernardino. On most outcomes, the city of San Bernardino typically competes with the city of Detroit in doing very poorly on a broad range of outcomes. Loma Linda has had a federally qualified health center there, but they just rebuilt it with cost $68 million. $10 million was a gift from a Native American tribe that has had a good relationship with Loma Linda for 100 years, and they gave $10 million towards the project. But in addition to the federally qualified health center that provides a lot of care, the top floor of this center is what Loma Linda calls a gateway college. What's the problem they're trying to address and how this relates to health? Well, in the great city of San Bernardino, only about 20% of high school graduates go on to any additional education. That includes even going on to a community college. So the top floor, that's this gateway college, is in a context of high unemployment and low skills. Loma Linda is providing job skills for high school graduates. The Gateway College provides short-term certificate programs like certified nurses assistants, pharmacy tech, surgical tech, community health worker. I've visited Gateway College, talked to some of the students there, and they just being at a Gateway College has opened their eyes, not just for this entry-level program, but some are talking about going to nursing school and going to medical school, completely transforming their socioeconomic trajectory, which will transform their health by addressing the need of the unemployment in the community. Now, what I want to tell you that what Loma Linda is doing and what we need to be doing more of is not an optional thing. It's exactly what the Bible says, and if you miss it in the Bible, the spirit of prophecy says we ought to be doing. And I'm going to share with you some insights from the 50th chapter of the book of Isaiah and from the book Ministry of Healing, and show you an example of what we can do. Isaiah 58, by the way, those of you who believe that the spirit of prophecy is a lesser light that points us to the greater light, this chapter is the most quoted chapter in the spirit of prophecy. It's like the lesser light is shining with unique brightness on it. She says this work described here is the work of every church. What is the fast God is looking for? For us to help those who are wrongly imprisoned, to lighten the burden of those who work for us, to let the oppressed go free, to remove the chains that bind people, to share food with the hungry, to give shelter to the homeless, to give clothes to those who need them, and not to hide from relatives who need your help. This is the Bible I'm reading. And if you do this, God promises your light shall shine in darkness and your gloom will become as midday, and the Lord will continually guide you. Wonderful promises to if we engage in this work. But just in case you missed it in Isaiah 58, when Jesus was here and he pictured the great scene of the last day of judgment, he says, God is going to separate the sheep and the goats based on, I was hungry and you fed me. I was thirsty and you gave me something to drink. I was a stranger. A stranger is a fancy word, Old English word for an immigrant. I was an immigrant and you invited me in. I was naked and you clothed me. I was sick and you visited me. I was in prison and you came unto me. And in case you missed the point, in Matthew 25, Desire of Ages says, thus Christ pictured to his disciples the scene of the great judgment day, and he represented its decision as turning on one point. Which day is the Sabbath? No, not that. There would be two classes. Their eternal destiny will be determined by what they have done or neglected to do for Jesus in the person of the poor and suffering. That's the work we have been called to do. What can we do in this work? We need to follow the example of Jesus. We need to walk in his footsteps. And we can find his footsteps beside the sick bed, in the hovels of poverty, in the crowded alleys of the great city. In fact, in every place where there is human need, that's where Jesus is calling us to work. God has provided detailed, comprehensive instructions, not only in the Bible, but in the ministry of healing. And I just want to show you a few quotations from the book Ministry of Healing. She's talking about the work that every church should be engaged in. And one of the things she said that Adventist churches should be doing is creating jobs for the local community, the church. Attention should be given to the establishment of various industries so that poor families can find employment. Carpenters, blacksmiths, doesn't apply to us. But indeed, everyone who understands some line of useful labor should feel a real responsibility to teach and help the ignorant and unemployed. She talks about job training. By instruction in practical lines, we can often help the poor most effectively. She talked about giving people in the community practical skills. That's what the church is about and should be doing, all spelled out based on Isaiah 58 and Matthew 25, spelled out in the book Ministry of Healing. She talked about a ministry of mentoring and adopting kids and providing parenting training. All of that is described. And you say, well, can we do that? Well, let me show you what the Adventist Church did more than 100 years ago. Let's take a brief walk down memory lane. In 1893, the General Conference of Seventh-day Adventists established, based on the Ministry of Healing and the writings at that point, John Harvey Kellogg, an Adventist physician at the time, read them and decided to implement them, and they put him in charge of this ministry. The Chicago Mission, 1893. What did it offer? A free medical dispensary, that's a fancy word, medical clinic, a clothing distribution program, a homeless shelter that housed 400 persons per night, a soup kitchen that fed 500 to 1,500 persons per day. Work at a shelter was available for persons who were staying in the shelter. A lifeboat rescue home, a halfway house of prostitutes, I'll come back to that in a minute, a maternity home for unwed mothers, a farm outside the city so that persons coming from Skid Row, drug addicts, had a place where they could detox and start over life, a school for Chinese. That is significant. This is 1893. In 1882, if you know US history, the Congress passed, House and Senate, and it was signed by the president, a law that was called the Chinese Exclusion Act. So this Asian hate is not new in this country. 1882, the Chinese Exclusion Act. If you were Chinese, you could not come to America. And that stigmatized, disadvantaged group. We had a special mission for them, a special ministry for them to help them to be survive in American society by learning to speak English. A visiting nurse service. This is information about the farm men reclaimed from Skid Row. This is the ministry to prostitutes they started. 4 women the first year, 4 upright Adventist women would go to the red light district in Chicago by night to talk to women who were working as prostitutes. Working in teams of 2, they would work until 1:30 a.m. And in the first year, they were successful in persuading 75 girls to leave the street and return to a better life. And if they left, the church had a halfway house where these women would be housed, as well as other unwed mothers who needed a place to live. We did that. In addition to what I've just described, this ministry developed a medical school in Chicago in 1895. This is more than a decade before Loma Linda Medical School developed. This Adventist church operated a medical school in Chicago. The students spent their first classes in Battle Creek, and then went to Chicago for the rest of their clinical work. The medical school had a settlement house. It was a home base for 8 visiting nurses who worked in the low-income residential area, meeting the needs of the community. Activities of the settlement house included a kindergarten, a day nursery for moms, a free laundry for women, a free employment agency, classes in first aid, hygiene, diet, child training, dress, a placement service for orphans, a placement service for men and women who had been reclaimed for Skid Row. I'm talking about what the church did in fulfilling its ministry more than 100 years ago. And what are our marching orders? Spirit of Prophecy says, in every city where we have a church, a place should be established where people are trained to do this work. She calls it medical missionary work. Not just health, but also helping people in practical ways. And she talks about the work of making a difference for the African American community and poor people in this country. She says in the book Southern Work, God spoke concerning the captivity of the colored people as verily as he did concerning the Hebrew captives. So wait a minute. She didn't say Abraham Lincoln freed the slaves. She said God spoke and said, I've seen the affliction of my people, I've heard their cry, and I have come down to deliver them. The Lord wrought, she says, in freeing the southern slaves, and he designed to work still further for them as he did for the children of Israel, whom he took forth to educate, to refine, to ennoble. In fact, in the book Southern Work, Ellen White says, American nation owes a debt of love to the colored race, and God has ordained that they should make restitution. That's reparations for the wrong they have done them in the past. This spirit of prophecy, I'm just reading this. Those who have taken no active part in enforcing slavery, which is what people say today, I didn't do anything, and the colored people are not relieved from the responsibility of making special efforts to remove, as far as possible, the sure result of their enslavement. I'm just reading this. Southern Work, page 54. Here's another statement where she makes the point, letter 98. She says, no people have suffered such great oppression as the colored people in the South. None have, through the treatment received, been brought into such degradation, and for no people so little has been done to uplift. They have not been taught to read that they might know the word of God. This field, the Southern field, stands forth to witness against those who have had the light of truth. She's talking to employees at Pacific Press, who have had their duty plainly presented to them, but have neglected to do what should have been done. Very strong language from the passivity that exists among too many Adventists today. What do we need to do moving forward? Ministry of Healing, remember, but this book, I'm telling you, has everything we need to know, says, how can we be successful in evangelism? Mingle with others as Jesus did, as one who desired their good. Show sympathy, minister to their needs, whatever those needs are, win their confidence, and then bid them follow me. Christ is waiting, church, with longing desire for the manifestation of himself in his church. He wants us to make the love of Jesus real to the communities and disadvantaged people in our society. When the character of Christ shall be perfectly reproduced in his people, he will come to claim them as his own. It is the privilege of every Christian not only to look for, but to hasten the coming of our Lord Jesus Christ, where all who profess his name bearing fruit to his glory. How quickly would the whole world be sown with the seed of the gospel? Quickly the last great harvest would be ripened, and Christ would come to gather his precious grain. I'm wrapping up now. I leave you with these words, the beautiful words of Scripture. A new commandment, Jesus, he says, I give to you, that you love one another. That's big. We need to love one another. But Jesus goes further. We need to love one another as I have loved you. By this shall all men know you are my disciples, if you have love. God has called us to make a difference in our world, in our society. We are here to address the health problems and the social problems that exist. Jesus came and pitched his tent beside ours, and God wants us to make a difference where he has placed us in our neighborhood. I'm a professor. I like to give homework. Don't believe what I've said. Dismiss everything I've said. but go home and study the 50th chapter of Isaiah and read and study the book Ministry of Healing. You will see the truth of what I've said today. All right, I've spoken for enough time. Time for discussion.
Wow.
Let's see what questions
Wow.
and comments you have.
Okay, Dr. Williams, thank you so very much for so expertly taking us through that whole narrative. Gentlemen, we have, and for those who are watching via the YouTube and Facebook, we have a studio audience of gentlemen who are in our Zoom audience, and I'm sure that they will have questions. We are also taking questions from those of you who are sending those questions in the chat on YouTube and via Facebook. I'm going to start off with a question that comes from a YouTube listener, and the question is, Dr. Williams, I know where these surveys are taken and how many people per. I would like to know where these surveys are taken and how many people per area did they do these studies. All of these matter can be high amongst Black than others.
I'm not sure which specific surveys the person is referring to. I have referred in my talk to many different studies. So it's hard to answer the question not knowing which specific study you're talking about. Some studies have been conducted. I gave examples of national studies which were not based on surveys. There's some national studies which are using census data, for example, or using data from other contexts. What I would say is the research I have reviewed all come from what I would call high quality research that was done, peer reviewed, published high quality research. But if I had more detail about a specific survey, I might be able to answer it more directly.
Okay, Dr. McCullough?
Well, there's one in the chat. I don't know if you saw it. It says, have any studies like this been done with Adventist data, where we look at the church and the disparity in the health and the income and all the other factors that you did with your presentation? I know we have the Adventist Health Study, but I don't know if we did some of the other things as far as the income and those other factors.
Yes, Doctor, that was a question from Volney. I don't know if Volney wanted to add anything else to that question. Volney, have you got anything else you wanted to add to the question?
No, I think Dr. McCullough.
Okay, excellent.
So the North American division has done a number of surveys on the Adventist Church. And so the income gaps that we see in society exist in the Adventist Church. And one of the things that's happening in the Adventist Church that we are not grappling with, I think, as a church, is the Seventh-day Adventist Church is not growing the native population of any race. There is a sociologist who studies Adventism, is his area of interest, and he shows, using data, including data from the GC archives, but he did work in New York City and other places as well, that the Adventist Church has largely become an immigrant church. 80% of new converts to Adventism in America every year are immigrants from the developing world. In most major cities, the majority of Seventh-day Adventists are immigrants. So most Blacks who join the church are immigrants from the Caribbean, from Africa. Most Asians who join the church are Asian immigrants. Most Latinos who join the church are immigrants. Even among whites, a high proportion of whites who are joining the church are immigrants. So we are becoming an immigrant church, and we are not winning the native-born population of any race. And I would argue, but that's a slightly different topic than what I talked about today, but it's something I have strong feelings about, is that when native-born Americans look at the church, they don't see us as offering a solution. I mean, racial division is a big issue in American society. It's a huge source of cleavage in American society. And we claim that the power of Jesus is able to overcome every problem. When it comes to the issue of race, somehow we act as if God's hands are tied. And they don't see it in us and in the way in which our churches are organized and function. And so I think that's a problem. Let me comment quickly on the Adventist Health Study. The Adventist Health Study, especially the most recent iteration of it, is a very large health study, the largest health study of Seventh-day Adventists. Unfortunately, the study did not use statistical procedures to draw a representative sample of the Seventh-day Adventist Church. I want to say this kindly. It wasn't because there wasn't expertise and information to those who directed the study to do this, but they opted not to do it for their own reasons. They didn't do that, so that although we have large numbers of Black and white Adventists, and there is one publication from the study that there's a publication from the study that looks at the health of Black Adventists compared to the health of Blacks in American society in general, and shows that Black Adventists are doing better in terms of health than American society in general. It's honestly comparing apples and oranges, because it's using, probability data for American society. It's using the Black sample in the Adventist Health Study, which is not generalizable to all Adventists, which has markedly higher levels. Those who responded to the questionnaire have higher levels of education than Blacks in America in general. So it's not really it's not a scientifically valid comparison. So I think we don't know, but I would say from the membership surveys that are done, the income profile of Adventism of Black Adventism look very similar to the income profile of Blacks in American society in general.
So,
okay, go ahead, Wally.
I should jump in, I apologize. So Dr. Williams, the question I actually wanted to ask was, when you went through all the data that showed the disparity between not just income, but between the predictability of how long someone would live, and that disparity between Black and white and Native Americans, I was in the Adventist Church, because of the Adventist Health Study and the outcomes of this, which show that Adventists live longer, whether or not if studies were done that were broadly within our Adventist population, that would also show that Blacks were living similarly to whites, or the same disparity you saw in the general population, you would also see the Adventist Church, which would come back to the factors that affect Blacks in general, affect Blacks in the Adventist Church being in America. And there's nothing particularly, or is there something unique about being a Black Seventh-day Adventist that extends your life or gives you greater access to income, increasing income over time? It's just understanding some of the myths that we have about Adventism, and whether or not those myths actually are real, or generally our population statistics mirror the statistics of the population in the United States.
So let me say a couple things. There is some data, but we don't have the perfect data to answer your question properly. So the early Adventist health studies showed that Seventh-day Adventists live longer on average than the average person in California, that those Adventists who followed the Adventist health message more closely live longer than those who didn't. So you get an 11-year difference in life expectancy compared to about a 6-year difference for Adventists overall, but 11 for those who really followed the health message. Those initial studies did not have many Blacks in the study. The trend was similar for Blacks, although Blacks tended not to do as well as whites. But I'm saying the numbers were small. The more recent study has much more data on Blacks. There are nearly 30,000 Blacks from the United States and Canada in the more recent Adventist Health Study, with over 100,000 people in it. I haven't seen much data. There's one paper I saw that looked at but it didn't look at the hard health outcomes. It looked at some self-reported health outcomes, and Black Adventists were doing not as good as white Adventists, but they were doing better than Blacks in the society in general. But it's hard to generalize on it, because they didn't draw the sample of Blacks in a way that gives it scientific validity that we could generalize it to blacks in general. So what I could say is, yes, the blacks in the Adventist Health Study were doing better. But let me come back to a second point. There is data. The sociologist, if someone wants to look him up, his name is Ron Lawson. He's retired, but he's done a lot of papers on the Seventh Adventist Church. And what he finds, consistent with what some of the beliefs are, is that Adventists historically have tended to recruit members from the working class of the society in which they live. But because of our historic emphasis on education, the next generation are middle class. So the Adventist Church does provide upward mobility on average, and that pattern is there. Now, whether that is still true today with contemporary, is a question, but he has documented that pattern. One other point that's intriguing, one of the things he has found is what he describes in the US of the Adventist Church becoming an immigrant church. That's true in Western Europe and Australia as well. So I've been to Adventist churches in Paris and Amsterdam. It's immigrants. You don't see many of the native born. You see people from the Dutch Caribbean in Amsterdam, people from Africa and Martinique and Guadeloupe in Paris. So he has shown it's a more global pattern where we are not really winning the native born population. And by the way, there's an explanation we have had that applies well to the white population, but not as well to the black population. That is, it is true that in most Western societies, that's true in Western Europe, it's true in Australia, for example, that the society is very secular, not as interested in spiritual things. So the fact that we have challenges in winning those populations makes some sense sociologically, that these populations are harder to win. However, America is a much more religious nation, and Gallup did a study some years ago. Black African-American population, Black people in America, is the most religious subgroup in the industrialized world, and we're not winning that group either. So we can't say it's secularism why we are not having more success in winning African Americans. And it's something as a church we need to grapple with and come to terms with.
Okay, so Dr. Williams, I'm going to take Pastor Henry, Dion Henry, then Dr. Holness, and then we have a comment in the chat. Dr. Holness will be addressing that. Pastor Henry, you had a question you wanted to raise or a comment you wanted to make?
No, just a comment, and maybe if the doctor shows some light on this. And again, excellent presentation that you did. What would be your suggestion for the Adventist Church to reach the indigenous people or the people that are native, especially here in America, given the information that you provided today? I see that there's a lot of mega churches that are, gravitating and really dealing with the social issues. What would be your suggestion for the Adventist Church now?
My suggestion for the Adventist Church is to do what the Bible and Spirit of Prophecy tells us we should be doing. I literally feel if we followed Ministry of Healing, page 143, that's not what we do. We are still using outdated traditional methods of evangelism. There's a crusade beginning in my town tomorrow night. And what are they doing? Have they done any work of mingling with people? No, they've just decided they'll have a campaign. And today there was all the churches met together to have a little rally among the churches and let's have a campaign. No primary work has been done. We haven't mingled with others. We haven't met the needs of people in the community. I mean, there are examples even within the Adventist Church of even in those secular societies, when we establish programs that meet human need and touch people at their area of need, we win them. But to say you can have a campaign, we meet in every night except Thursday night for 3 weeks, and we have no pool of people that we've been working with, that we've befriended, that we have ministered to their need. We just throw it out and advertise. That's not what we've been called to do. So I think if we actually did what we were called to do and use that model of being known as, put it this way. In many communities, now I don't know what's happening in Orlando, so don't, and other places, okay? So I'm not making a judgment there. In many communities, if the Adventist church closed, would people miss us? Are there any need we are fulfilling in the community? Are we making a difference in the lives of people? In some places we are, but as a whole, there is, and my point is, it's not that we don't, maybe we don't know, but it's not that it hasn't been spelled out to us exactly what are the keys to success, and we're not following those keys. And so we're doing traditional things of using Revelation seminar, Bible-based stuff for people who are not interested in the Bible. But for example, even in Australia, I was impressed that they're doing a lot more with, they're doing a forgiveness seminars, and they're doing stress management seminars, and they're trying to meet people with some of the needs and challenges they're facing as a way to do it. But there are multiple examples. In fact, I have some friends in Ocala, Florida, who are doing an amazing job with outreach even on Sabbath afternoon and meeting the dental needs and the medical needs of the community as an example of what could be done. But I just think we're not taking heed. That's why I gave everybody a homework assignment. Don't take what I said. Read Ministry of Healing, study Isaiah 58, study Matthew 25 of what Jesus says his followers should be doing.
Dr. Holness?
Hey, Dr. Williams, thank you very much for the presentation. This may be a two-part question, but I've looked at some of your presentations, and if you guys get a chance, some of the listeners, to look at unnatural causes, Dr. Williams is involved with a number of other researchers in looking at racism and health. When I went to medical school, racism was not really looked upon as a health issue per se. And now that we have health disparities and that sort of thing, we're looking more and more into it. So Dr. Williams, I've looked at some of the statistics. When you look at life expectancy worldwide, we see that Japan, I think, leads. Japan at least was number one. I think Hong Kong or one of the Asian countries are like number one when it comes to life expectancy. America a few years ago was ranked, I think, 35th.
That is correct.
I think it's now 44 or 45. What I'm trying to say, and just with your presentation, and you're the researcher, is that there's a root problem here. If you look at America, America compared with all the other westernized countries, our life expectancy overall, that include whites, Asian, African Americans, Hispanics, we still rank as number 45 or even lower. And when you look at our church, the mentality of our church is the same mentality as America. If you look at some of the other westernized countries, they have universal health care, they have employment, they've made a lot of social changes. We have not made those social changes. You brought up the example about maternity care and maternity mortality. Our maternal mortality and infant mortality is highest in African American and minorities. So the root problem, when you look at the church, Adventist Church and other churches are just a reflection of America's understanding of race, individualized, institutionalized, and it's very complex. So the question I have is, I don't know, you mentioned some of the solutions, but the church is just reflecting the issues of how we look at race, not only from the 1800s and Ellen White, but we're still doing it now. Look at the politics that we have. Look at how it's divided. You have the Dems trying to do more social change. You have the Republicans trying to do other changes, but not reflecting on race. But you see how it affects race. We had the killings in Atlanta just a week ago. We have voter suppression taking place as we speak in the Georgian, Congress and state. So the point I guess I'm trying to make is that this is a bigger thing. We look at America and how we've done different things in social change, but America is not withholding or taking grasp of those changes, and the rest of the world is moving forward with those changes. I just want to make that, just any comments that you can make.
No, it's a good point. The rest of the world is doing better than we are on some outcomes, not as well on others. So you're absolutely correct on the life expectancy data. In fact, in the data where America ranked 35th, if white America were a country, it would rank 33rd. I mean, Cuba has better life expectancy than the US. Costa Rica has better life expectancy than the US. Yes, the Scandinavian countries tend to do very well. Japan tends to do very well. And not only are we doing poorly compared to other countries, we are losing ground over time. In 1980, America was 10th in the world on life expectancy. And so every year we're doing worse. There was a study from the National Academy of Sciences that shows that the best of Americans in health, those with a college degree who exercise and don't smoke, they have the best health in America. They have worse health than their counterparts in Western Europe who are college educated and don't exercise and don't smoke. So all Americans could be doing better in terms of health. And one of our problems in American society, where again, the Adventist Church is positioned with our historic emphasis on prevention. One of the problems in American society is that we look to medical care as the solution to our health problems. And don't get me wrong, I'm going to say something that may surprise you, but it's absolutely true. Medical care as practiced in America does not have much to do with health.
Oh, wow.
What I mean by that, listen to me carefully. I have a doctor, I have a good doctor. I go to my doctor, I follow what he tells me to do. But most of the practice of medical care in America is a repair shop that takes care of us once we get sick. It's not a driver of whether we get sick or not in the first place. There's studies that put that the contribution of medical care to overall American health as somewhere between 10 to 20% of variation in health in adults is accounted for by medical care. Most of it, 50%, is linked to what I've been talking about. The conditions in the places where we live, learn, work, and play, those are in fact the drivers of health. One of the things I want to say, and I want to say gently, since I know, at least the program is based in Orlando, where we have the largest Seventh-day Adventist hospital in the United States, probably in the world, 1,000-bed facility, and so forth. And we have a health system. I have sometimes said to churches, I said, true or false? The spirit of prophecy says the medical work is the right arm of the message. And people usually say true, and I said it's false. She never says the medical work is the right arm of the message. She does say that gospel medical work, and she does say that medical missionary work is the right arm of the message. My point is, if all we do is medical work, we're missing the boat. It's gospel medical work and medical missionary work. So one of the things we could do, our health systems could do, is have a greater emphasis on prevention. Now, this is difficult in the reimbursement type environment that we live in, where you're going to survive based on what you get reimbursed for, and we don't, our system of care does not reimburse prevention. It's a more focus on curative procedure, so it's a challenge. But to the extent that we could, a greater emphasis on prevention is where the solution is, and that is widely recognized by, this used to be a novel idea, it's not a novel idea now. Most experts see that. Let me give you one stat. The US ranks near the industrialized world, as your question so beautifully said, on health. Do you know America, that is less than 5% of the world's population, according to the World Bank, half of the money spent on medical care worldwide every year is spent in the US. We consume 1/2 of the world's medical resources, but we rank near the bottom of the industrialized world on health. So it's not healthcare alone. By the way, on the issue of racial inequities, other countries are not doing much better than us. I showed you the data for England. I could elaborate on it, and I have more data on England. But in England, where everyone has access to the National Health Service, I showed you that the racial gap in England for Blacks is wider than in the US. on COVID-19. I have data on maternal mortality in England for Blacks. It's very similar to the data for the US. I have data on infant mortality by race in England, very similar to the US. So again, medical care is important and everyone should get access to care and access to high quality care, but medical care alone will not solve the problem. And if you look at data for South America, the indigenous populations in South America, the African descended population, you look at data for Australia, New Zealand, we have the same racial gaps everywhere. So I could not point to a society that has been successful in really, in a major way, eliminating the racial gaps in health.
Okay,
I
Dr.
had part. Hey, Marcel,
Okay, go
just
ahead.
part
Go
two,
ahead.
real short. It's just a combination, part two. I'm including Volney's question. Volney had a question on the chat, Dr. Williams, and his question was, and I'm going to kind of paint this in zip codes because you brought up zip codes.
Yes.
Volney's question was, should we live in white neighborhoods? So hold on, Doc. When you paint the picture of zip codes, and I've seen your documentary when you talk about physiology and how stress affects the blood pressure and heart disease, I want you to wrap that into zip codes. I want you to wrap that into access of healthcare. I want you to wrap that into better schools.
Yes.
And does it really give us less stress if we're in a white neighborhood? I want to throw that one out, Doc.
It's a really great question. Let me say an important point. So I've talked about the fundamental problem of segregation of your neighborhood and opportunities in your neighborhood. There is nothing inherently negative about living next to people of your own race. So the problem of residential segregation is not segregation per se. It's the clustering of social ills that occurs when you have people living under conditions of concentrated poverty. Just imagine with me for a second, a teacher in an elementary school that has 25 students in her class. 5 of the students are poor and 20 come from households that are not poor. This is a good class. But imagine a teacher in an elementary school with 25 students and 20 of them are poor. That teacher is now a social worker. She doesn't have time to teach. Poor kids bring all the social problems to class, to school with them. So it's a very different environment. So it's a concentration. And that's what's happening in America. I'll give you an example. In metropolitan Chicago, the correlation in elementary schools between percent poor and percent Black and Latino is 0.90. You know percent poor, you know percent Black and Latino. You know percent Black and Latino, you know percent poor. The two things hang together. Historically, there have been more poor white kids than poor Black kids or poor Latino kids, but most poor white kids went to schools where the majority of kids are middle class. Most poor Black kids are going to school where the majority of kids are poor. And it's a very different environment. What I would say, if you live on average in a white neighborhood, you are more likely to have lower levels of some kinds of stress, but higher levels of other kinds of stress. So what research finds, there's studies in England and studies in the US that find that levels of discrimination, racial discrimination, are lower if you live in a neighborhood where your community of people like you in terms of race. If you live in a neighborhood where more people are white and you are a minority, on average, the levels of discrimination are higher, so that there is a protective level of association with more persons of your own race in terms of exposure to discrimination. But in terms of access to opportunities and facilities and quality, it's often is better, unfortunately. There are a few areas of the US where there are large Black communities in Atlanta and metropolitan DC, where most people are middle class, and there's nothing problematic about that, but those are rare in the United States overall.
Okay, Dr. McCullough, I see your hand, but I'm going to take Malcolm from the chat who had a question, and then get back to you, Dr. McCullough. Malcolm, you want to go ahead with your question? Are you still there, Malcolm?
Yes, I'm still here.
Okay, go ahead.
Okay, so Dr. Williams, I was listening to your stuff, very eloquent, very beautiful. Immigrated to the United States and had the exposure of teaching in middle school and high school. The thing is this: I'm noticing that you outlined the changes among the blacks and the whites, and we see the disparities all the time. But what I want to know is I know you're speaking about a lot about Adventists. I'm not an Adventist, but I'm a Christian. I want to know if the concentration of your study is focused on the Adventist people, the Black Adventist people, because I know growing up in Guyana, South America, we went to every church our parents sent us to. So a lot of my influences came from the Adventist church, even though I was not a member of the Adventist church. So I want to know if in your discussion that you're making, is there any scope for the collective church, the Black church, the believers of Christ, collectively seeing the disparity of sin and unconsciousness of sin as compared to us as Black people just living? Is this study focused more for the Adventist believers or generally for all Christian believers in this community?
Thank you for the question. I'm really glad you asked it, because no, the issues I'm raising, I literally have shown no data here that is unique to the Adventist Church. The data I'm showing you is national data from studies in the US. So I think of myself as speaking primarily to a heavily Adventist audience. So I am giving an emphasis on Adventism, but no, the issues that I'm raising are issues for all of Christianity and all followers of Jesus. We have been called to make the love of God real in the world. John 1:12 says Jesus came and he in the original Greek, it says he pitched his tent beside ours. He moved into our neighborhood and he made a difference in the lives of people. And that's what we have been called to. So this is not, I am giving an emphasis to Adventism because of my presumed Adventist, heavily Adventist audience. But no, this is for all of us Christians in terms of what we have been called to do as a follower of Jesus.
This is so beautiful. I would really want to be able to. Do you do this often, every week or so? I'd love to be a part of this kind of
You're
stuff.
more than welcome to be a part of us, brother.
Oh man, this is beautiful.
We'll share the information with you. Okay, so Dr. McCullough, I'm going to take you next, then Lamech, and then Lawrence. Lawrence had a question in the chat. I'm going to give you guys a chance to ask a question. Dr. McCullough?
Well, it's the other Dr. McCullough.
Go ahead.
Judy, nice to see you.
Hi, David. Good to see you too. My question is this. You talked about the Chicago experiment. That's what I'm calling it, the Chicago experiment, where the Adventist Church developed this following more in accordance with the spiritual and spirit of prophecy with the Bible. What happened to the experiment? Is any part of it in existence? Did something happen? Why it has not been replicated?
The problem with Chicago, it's complicated. It had to do with the director of this program who had a vision was Dr. John Harvey Kellogg, and he tried to implement this comprehensive program. Dr. Kellogg was a complicated person. One of the things that many Adventists do not know about him, he was an early Adventist. I sometimes tell people that Adventists taught America how to eat breakfast. It was Dr. Kellogg who invented cornflakes. Yes. He invented cornflakes as an alternative to bacon and eggs for breakfast. It's Dr. John Harvey Kellogg who coined the term granola from this cereal that he made. And it was Dr. John Harvey Kellogg's brother, Will K. Kellogg, who was the business manager of the hospital in Battle Creek, who went out and started the Kellogg Company. And that the Kellogg cornflakes, it grew out of an Adventist family. But let me tell you a little about I'll come back to Chicago because I want to say something about Dr. Kellogg. I saw a post on Facebook once recently that I had to respond to about Dr. Kellogg. Dr. Kellogg, in his early life, was a champion of racial justice. He and his wife, living in Battle Creek, Michigan, did not have any children of their own. But over their lifetime, they adopted more than 40 kids that they raised in their own home, including Black kids. Now, that was a fundamental no-no. You don't raise Black kids in the same house with white kids back in the 19th century. And that's what he did. And he did it as the right thing to do. His parents, as many other early Adventists, operated a station of the Underground Railroad on their farm outside Battle Creek, Michigan. That was true. John Byington, the former president of the first president of the General Conference, operated a station of the Underground Railroad on his farm in upstate New York, transporting, helping Blacks to escape to Canada. So many of the early Adventists, some of them were champions of racial justice. Ellen White was also a champion. One of the things that happened, but you see, some of the brethren didn't like Kellogg's view. He was too liberal on these racial issues, okay? And so one time Kellogg went out of the US. He was the health guru in America then. US presidents, the Henry Fords and so on of the world at the time would go to Kellogg and Battle Creek for their health care and for improving their health. He was the health guru in America, very famous. And one time he went out of the country on a trip. The Battle Creek Sanitarium was where people would come for treatment. And he had Black workers there. While he was away in the cafeteria, they put a curtain up. So the Blacks would sit on this side, the Black workers would sit on this side, and the white workers would sit on the other side. When Kellogg came back and he saw the curtain, he said, if I'm gonna be the medical director here, tear it down. He made them tear it down. They did it, but they weren't happy. So I'm just saying, we have seldom told that one of the sources of tension that Kellogg had with church leaders was he was more progressive on the racial question than many of them were. And his work in Chicago reflected a ministry to those, not just race, but those who were socially disadvantaged in society. What happened, long story short, Kellogg also developed views of pantheism, where he believed that God was in the tree and in the plant and in the flower, and God was in everything, and actually wrote a book and was publishing it, and the publishing house, the Adventist publishing house that published his book, there was a fire that burned it down while they were publishing the book, during the time when they were publishing the book. So I think pantheism was the last straw that broke with him, and so he left the church. So part of it was the charismatic leader who was the driver and the visionary left the church around that time. And so the medical school in Chicago closed down and the whole program closed down. What is a stain on Dr. Kellogg's legacy is that early in the 20th century, around 2015, he was still alive and active then. He became actively involved in a group. He was always interested in the betterment of the race, but he took the path of eugenics as one of the ways of betterment of the race. And so some people focus only on his drift to a eugenics group that where Hitler says he got his ideas of race science from the American eugenics movement. And Dr. Kellogg got involved in that movement. And so, which is not a positive thing, but it's his early years. He was, in fact, a champion of racial justice within the church.
I just want to remind viewers that you are welcome to put your questions and your comments in the YouTube chat and on Facebook chat. And we will try to address those questions as much as we can. Lamek, you had a comment in the chat. You want to expand on that?
Yes, Brother Marcia, you can read my question. I'm in a noisy environment. I'm sorry.
Go ahead and read it. Go ahead and ask your question.
Oh, okay, I see it. Dr. Williams, you illustrated well the systemic institutional racial disparities that work against us. What hope is there for an average African-American male, and your professional advice to an individual effort? What I would say to you, God is still on his throne. There are forces, there is discrimination, it's real. I am an immigrant to the United States, and I still think America is a land where there is opportunity in spite of the barriers you might encounter. And I would say one of the things the racism that's in our society means is that you need to bring your A game. You need to do your best, which is what we should do as Christians, that whatever our hands find to do, we do it with all our might. But the what I'm saying is, because you are Black, you can't, there are other people who could half step and still make it. You've got to bring your A game. A commitment to excellence is a key to success. Give your life to God. Ask Him to lead and direct you. And in spite of the barriers that exist, there still is opportunity, and I would encourage you to move forward. And what I would say to us, like myself, who are immigrants, I feel, I live every day with a sense of consciousness that even the opportunities that God has blessed me with, opportunities that people gave their lives for the doors that I am able to walk through. And so the Bible says, unto whom much is given, of him or her shall much be required. And so I see myself as under obligation, because of the blessings I have experienced, to make a difference, to lend a helping hand, and to try to improve the lot and enhance opportunity for all persons in the United States, of course, for all persons, but especially for the historically disadvantaged groups who have fought and struggled for equality and still don't have it, as the laws that are being voted to disenfranchise them illustrate. And I went to graduate school in a minority fellowship. And when people campaigned for minority fellowship, they weren't thinking of a poor boy growing up in Castries, St. Lucia. So I don't apologize for how God has blessed me, but I do feel I live with a sense of obligation and responsibility I have, that I can't look the other way. I have to work to make a difference for all, especially the historically disadvantaged in this country.
Okay, I'm going to take Lawrence, then Dr. McCullough, and Dr. Holness. Lawrence, you had a question in the comment in the chat. You want to expand on it?
Yes, thank you. Dr. Williams, listening to your presentation has reinforced, I would say, in me this fear that I had a long time, that as a Christian, many of us are thinking of ourselves as doing the right thing, but we're not doing what God is requiring of us to do. And that is what was specifically stated in Isaiah 58, verses 6 and 7. I'm thinking, seeing that you've presented this reality that the Adventist church in so many parts of the world is mainly an immigrant church, is it also an indication that we really are not working with our community? We really are not living up to the expectation Christ has for us, and we are in mortal danger of being considered being among those who think of ourselves as standing, who will say to Christ in the last day, Lord, Lord, have we not done all of these things? And he will say to us, depart from me, I know you not. Aren't we in grave danger? Isn't this an indication that we're in grave danger of such a thing happening?
It's a really great question. It's a sobering question. I don't want to paint with too broad a brush. I'm not suggesting by any means that every Adventist church faces this challenge. I encourage from time to time when I see churches that are really trying to make a difference, and I've seen it recently in my area. There are churches that have a shorter 11 o'clock service because once a month they finish the service early because everybody comes in regular clothes, because from service, they're walking into places to make a difference, or where they have prearranged to go and to work and to make a difference in the lives of others. So, and there are other churches that are doing that as well. And part of what I've said about Adventism is true of Christianity more broadly in many ways, although again, there are in every city, there are places where people are making a difference. But you are right. I think it is a call for all of us to really, let me put it this way. Sociologists who study the religion make the point that the Christian church in America. They're talking about the Christian church in America. The term they use, the Christian church is culturally captive. What they mean by that is, although we claim to be following the Bible and we claim to be following Jesus, if we actually looked at what we do on a day-to-day basis, what our priorities are, what values drive us, we are driven by our culture. In fact, I sometimes listen to Christian radio, and some of it is to the political right. Sometimes if you listen to them around election time, you believe that the Bible calls for America to be a strong nation and spend more on the military, because they have baptized a political party's ideology as if it is Christianity. So yes, there is a danger we have to examine ourselves. And you're right, when you started Isaiah 58, it's not the only one. He has showed thee, O man, what is good, and what does the Lord require of thee, but to do justly, to love mercy, to walk humbly with thy God. It's the prophets have this message of making a difference in the lives of others, and a commitment to justice and equity. And we believe that the world will not become perfect on this side of eternity, but we are to make a difference where we are, with the opportunities God has given us, and we can make a difference for many of his children in what we are able to do, even as we recognize there is a great cataclysmic event coming that's going to make the permanent, lasting change that we want to see.
Okay, just before Dr. McCullough, there's a question from the YouTube channel here on the conference website. It says, are there comparative studies of health disparities between West Indians and Afro-Americans?
I have not. There are not many, because the West Indian population is relatively small, and so there are few studies. However, I was involved with one. At the time, it was the largest mental health study done, and we included an oversample of West Indians, but it was primarily a mental health study. We have self-reported indicators of health. What we found in general for West Indians is something that is found for all immigrants. So if you look at national data for the United States on overall life or overall mortality or infant mortality, there is a healthy immigrant effect. Immigrants of all racial groups have better health than their native-born counterparts. And that is, Black immigrants have better health than Blacks born in America. White immigrants have better health than whites born in America. Asian immigrants have better health than Asians born in America. Hispanic immigrants have better health than Hispanics born in America. So across the board, you have better health. However, with increasing lengths of stay and generational status, the health of immigrants declines. And it declines much more for Blacks and for Hispanics than it does for Asians. Higher levels of education and income for Asians seems to cushion some of the decline. There is decline for Asians, but bigger declines for Blacks. So, however, there are some challenges that West Indians face. So let me share with you one finding. So we were looking at mental health. In general, on mental health outcomes, like the major common mental disorders, anxiety disorders, depression disorders, Blacks actually do better than whites. African Americans do better than whites. Caribbean Blacks in the United States do better than whites. There is one exception to the pattern that we have found, and it's sobering. And that is, there is elevated risk of depression among Caribbean Black men in America. So we find that Blacks of Caribbean origin have higher rates of depression than African American men, and higher rates of depression than Caribbean women, which is not found in almost every society in the world. Women have higher rates of depression than men. That's true in America in general. It's true for African Americans. It's true for whites. Among West Indians, it's not true in America. Our best explanation, because we didn't have the data to fully unpack why that is the case, but we looked at some qualitative studies in New York and some qualitative studies in London. It seems that migration to the United States, on average, now remember, we're talking about in general, there are exceptions to this, leads to better economic opportunity for women West Indian women than for West Indian men. West Indian women seem to go into niches of teaching and nursing where they do well economically. The men coming from a more patriarchal society are not doing as well as their wives who are enjoying new liberties and economic success in the workplace are bringing these new liberties in at home. So the men are struck with they're not doing as well, the wives are doing better, and now they have a liberated woman on their hands to deal with. So that is our best explanation for why is it that depression is higher on average, there are exceptions, but on average for West Indian men in America than for West Indian women and than for African Americans.
Wow, you're not giving us much hope, Doctor. Dr. McCalla, you can go ahead with the question.
My question was about the effect of all of the racism on whites who try to maintain a society. Has that been studied in any way? How it's affected their health? Because to maintain that must take something out of them.
It is. There is data. One of my former students and it's a paper she's been planning to write for a long time, who wrote a paper, we published it 2 years ago, on the effect of whiteness on the health of whites. So one of the practical consequences is, and this has been documented, that historically, when Social Security Act was being debated back in the 1930s, there was discussion of possibly including a universal healthcare plan. It was opposed by Southern politicians because that was going to help Blacks. So because they have taken a very stringent approach on a number of things, there are books written about this. I'm not making this up. This has been documented, that America does not have as good a social safety net as Western Europe has, because politicians in America have been opposed to any efforts that would help poor because they think it's a program to help Blacks. In fact, research shows that a lot of the white opposition to Obamacare is the feeling that Obamacare was a new federal program that was helping Blacks. If you saw the data I showed you, there are more poor whites in America than poor Blacks. So they have hurt whites in this process. And that's why we have the opioid pandemic among whites in America right now. Whites who have less than a college education, very high on opioids, because the lack of opportunity and the policies that are being implemented are hurting them. But some of the drivers for the policies, the motivation of them is we don't want Blacks to benefit. So for example, many people don't know this. If you look at, and we think that it has, I haven't studied this myself, but I think it has something to do with the socialization of white males in this country. If we look at suicide rates tend to be high among young people. Probably the highest rate of suicide among young people is among Native American youth, where you find the highest rates of suicide. But if you look at all the suicides in America, over 70% of suicides in America are white males, older white males. So why is it that when white males get old and retired, they kill themselves at a very high rate? That's the majority, the overwhelming majority of suicides in the US are older white males. And some believe it has to do with their sense of what they're entitled to, and now they are losing this sense of power and so on, and they can't cope with it and commit suicide. So it's complex. There isn't, I would say, Lenny, there isn't a lot of research on that, but I have a student, former student, she's now a dean of a school at Virginia, but she was one of my doctoral advisees, and she's been very passionate about this and has written a paper laying out some of the research questions we need to do in the area.
Dr. Holness, go ahead.
Yeah, Dr. Williams, there was a question on YouTube. So this can be a part 2 question. One question on YouTube and then a question that I had. Kay Lee asked this question: are there any studies on the disparity of COVID-19 vaccine sites in African-American areas versus the suburban areas?
I have not seen any studies. This is all quickly unfolding. I am certain that there will be studies because there are people motivated to look at this question. What I know, I have seen media reports. So I saw a media report and a picture. This was in the New York Times or Washington Post, one of them, that showed some community health centers in Washington, D.C. that are serving people of color in Washington, D.C. And the majority of people in line waiting for the vaccine as these centers are white, because apparently there was more hesitancy in the community and white folks. In fact, the people who, I haven't said this, but the people who worry about the vaccines, and there's a lot of misinformation. I don't blame people. There's a history, number one, in terms of how Blacks have been misused historically. And there's a lot of misinformation, some of which appears to be credible online. I know because lots of people keep forwarding little YouTube videos to me that someone said this online. And so there's a lot of misinformation, but I would encourage people to get informed from credible sources. And personally, I just got my first dose of the vaccine as soon as I could get it last week. So I'm scheduled for the next one, well, a week before, in about another week, 10 days or so. So I believe that the vaccine were done quickly, yes, but there was no effort to do shortcuts. I am part of a group of 64. All of the Black members of the National Academy of Medicine have created a video and a site and had a New York Times piece where we say, we understand the concerns of the Black community, but we believe in the vaccines. We will take the vaccines as soon as we can get them. We think it's something we should do. But what I know in general has happened is, given the community have been at higher risk, in terms of establishing the priority, those neighborhoods that particularly Black and Latino and Pacific Islander and Native American should be prioritized as areas that should be offered a vaccine. And we do need to work with community. I don't think it's a bad idea for Black people and other people of color to have questions, given the history of abuse that they have experienced in this country, but to work with community leaders so that people can really, truly get the facts.
Doctor, just before you ask the second question, Dr. Kenny,
Okay.
I just wanted to piggyback on that question that Dr. Williams just raised. I'm wondering if the medical profession has proverbially shoot themselves in the foot, in that we have been schooled with the idea that it takes 10 years to produce a vaccine. And what has happened now is that we have had a vaccine within 10 months. So the idea that individuals have is that, hey, it takes 10 years for a vaccine to be produced. Here is a vaccine produced in 10 months. Something must have gone wrong. Would you be able to address that concern? And how can you help us as Black men to say, hey, yes, this is worth the safety of my family, the safety of myself, and all those I come in contact with?
So this is really a good question. There's no question the vaccine was produced faster than the typical vaccine, one. There was one vaccine that was produced in 4 years previously. But the reason the vaccine was produced is federal dollars. Many Americans don't realize the vaccines are free to all Americans. Why? Because that was the deal the Trump administration made with the vaccine companies. The Trump administration invested billions of dollars. I have a slide from another presentation that shows how much money was invested in these companies to produce the vaccines. So usually vaccines have to, producers, pharmaceutical companies, have to get research and development dollars to have the money, and they have to have the promise. Here is a case where they were literally, each of those firms got hundreds of millions of dollars to do it. So this was a windfall that they could begin research and development immediately and on a larger scale than would typically be the case if they had to invest their own money, which is normally the case, to develop it. So the federal provision of considerable financial resources made it. And one of the deals was that when the vaccines are available, they'll be free to Americans because of how much money the federal government invested to make it possible. So that's part of that's one factor that's different. The other factor that's different is just the advancements of medical science. There was technology used in the Pfizer vaccine had not been used before in a vaccine. It's not new technology, it's new to producing vaccines, but it's a technology that is being used in medicine in many other areas. So I think it's a combination of new technology that's available that capitalize on, but also the influx of a lot of money that pharmaceutical companies didn't have to raise. Here was the money available for them to test and go at full speed ahead in producing the vaccine. And no question, the fact that this was a worldwide pandemic. One other point, there was, the Moderna vaccine, a lot of the key development of the Moderna vaccine was done by a Black woman who is works for Dr. Fauci, is a co-lead of his vaccine development program at that NIH institute. That Moderna vaccine literally grew out of her postdoctoral project, and she ran it. So it isn't just that white people did it. When I give a talk on vaccines, I show a picture to show, and she's in her 30s, 33 years old or something like that, who played a key role in the development of the technology that Moderna used.
I had a part two.
Yep,
but just to follow with Dr. Williams, another thing I heard was the volunteers, the number of volunteers during this time. We're all motivated to try to find an answer to this. So the number of volunteers to show up, to try to recruit volunteers takes a lot of time and money and effort, but there was a lot of motivation with the volunteers. And the other thing is that there were a lot of, like you said, globally, a lot of companies that were working on this back in 2006, 2007, when they had the other, the original SARS,
yes,
MERS and everything else. And then the congruence, you have so many different companies working all together at the different phases and helping kind of working together. So I think that was the motivation. Mm-hmm. My second question is this, Doc, cultural competence. You spoke about cultural competence, and you basically mentioned the concept, Black doctors do better to care for Black patients.
Yeah.
The problem is that when you look at the numbers, how many number of Black doctors are there? How many number of Black optometrists? How many number of Black nurses and PAs and NPs? In medical school, they were working on trying to do better cultural competence. Are they making headway in medical schools to change the idea of cultural competence and to encourage and increase the number of Blacks in our communities, our students in our communities, recruiting them to become doctors and nurses and go into medical? Because at this point, the percentages are still very low. And we're getting a backlash now with reverse racism and you know what I'm talking about. So, I mean, is there an effort to increase the number of Black doctors, Black professionals in the medical health profession, since Black doctors seem to do better taking care of our Black community?
Yes, and I'll tell you what the research also shows about Black doctors. Black doctors, on average, more likely to practice in underserved areas. Black doctors are more likely, on average, to practice in primary care specialties. Those are priorities for the healthcare system to ensure that individuals have access to primary care. So that, health policy analysts point out that increasing the number of underrepresented minorities in medicine is a good thing for the system. That's number one. Number two, the problem you talk about is real. In 2014, there was a report from the American Association of Medical Colleges showing that there were fewer Black males in the first year of medical school in 2014 than in 1978.
Wow.
Fewer Black males across all medical schools in America. Fewer Black males in 2014 than in 1978. So that it's true for Blacks, it's true for Latinos, and it's true for Native Americans, even among those of their group who are in medical school, the majority are female. And it's great to have women in medicine. That's not the point. But we need to do more to recruit more males into medicine. One of the challenges we face, everybody in corporate America, in medicine, in medical schools, in healthcare systems, everyone is talking about cultural competence and diversity and so on. But a lot of what happens under that rubric is window dressing, as opposed to real commitment and the real investments to make a difference. One of the problems we face, particularly not just medical school, but the health professions, there's a lot of effort being put into recruiting underrepresented minorities into the health professions, but right at the point of application. What we really, really need is pipeline programs. If I said you are living in disadvantaged neighborhoods where the quality of elementary schools, the quality of high schools are inferior, then by the time you get to college, if you get onto college, you just don't have the same preparation as the others did. So what are we going to do to invest in summer programs to increase opportunity and increase enhancement to compensate for the deficits that they experience in their early education? That's where the need is for the big investment. And there are places like, to pick an example, the Harlem Children's Zone, that shows they eliminated the gap, the black-white gap in academic performance in elementary and middle school in New York by the quality of the program they offer. So if our kids are bright, our kids can learn. If we give them the opportunity, they will learn, but most of them aren't getting it. And we are not doing enough as a society in investing early so the kids will be successful. So that's where we need to put more of our efforts. There are some programs, there are some universities that are doing that, but it's still a drop in the bucket in terms of the need. And the other point to keep in mind, America is becoming much more diverse. Latinos now outnumber African Americans, but I also worry about Latinos because over 60% of Latinos are Mexican Americans. And one of the problems, even with the data I shared with you today, I'm sharing with you the data as reported by researchers or the government. But when I show you the income for Latinos, that is misleading, because that's the income for all Latinos. But Cuban Americans and South Americans are doing a whole lot better than Mexican Americans and Central American immigrants. In fact, Mexican Americans as a group are doing more poorly than African Americans when you look at education, even for the second generation. So we really have challenges that we need to address.
Okay, just to let you know that we will be losing our feed from the Southeastern Conference in about 10 minutes. I just want to change the trajectory a little, Dr. Williams, and ask you to address what the country is currently going through with the trauma of the trial of George Floyd. Sorry, not George Floyd, not his trial. The police officer who allegedly is involved in George Floyd's death. We are hearing from the court case so far this week quite a lot of trauma for those who saw, those people who were there, the country on a whole who saw someone's life being snipped out of them. Speak a little to the trauma that people experience and how this sort of trauma affects our physical health and what effect it will have on the society later on as it relates to racism in the event that this officer is found innocent versus if he's found guilty. What are some of the causation and what are some of the effects that will have on the society at large?
Let me answer the question by describing some studies I've been involved with. So I was involved with one of my postdoctoral fellows, Brandisha Tynes. We did the first study of online racial discrimination. So we looked at young people, middle and high school students. We looked at time spent online. We looked at the frequency with which they reported in some online contexts. There was a racial slur, they were attacked. We looked both at what they observed, might have seen occur, but what happened to them. And we documented that experiences of online and Black students, we had Black and white students in it, Black students experienced more online discrimination than white students. And the experience of online discrimination online was associated with an increase in anxiety symptoms and depressive symptoms in those kids, independent of a measure of discrimination offline and independent of a measure of adolescent stress in general. So we were documenting the unique contribution of online discrimination to the mental health of kids, and these were middle and high school students. My colleague, Brendisha Tynes, this second paper I'm describing, I had nothing to do with, but she did a paper published in 2019 showing that among Latinx and African-American kids aged 11 to 19 who have seen online more videos of someone from their racial group being arrested, beaten, and shot by the police had increased levels of depressive symptoms and PTSD. So documenting. Let me tell you about another study I was involved with one of my former students. We looked at a database of every police shooting in the US over the prior 3 years. And then we looked at another database from the CDC that looked at the mental health of the population of every state. And we were able to show, using a quasi-experimental design, the way we analyzed the data, that every police shooting of an unarmed Black male led to worse mental health for not his family, not his friends, but for the entire Black population in the state in which it occurred for the next 3 months. Mental health worsened for 3 months after a police shooting of an unarmed Black male. And it was a specific finding. It wasn't every police shooting. If it was a police shooting of an armed Black male, there was no negative effect. It's only the police shooting of unarmed Black males that led to the negative effect. So it seemed to be, it's the perception that people saw this as unfair, as preventable, but also because it was an unarmed person, people had a sense of their own vulnerability. This could happen to me. This could happen to my husband. This could happen to my child. You're unarmed and they still kill you. How do people make sense of this? So what I'm saying is we know there is worsening mental health linked to these exposures. I have been following, I haven't been watching it live, but I follow every evening the trial of the policeman in George Floyd's death. The evidence that is emerging to date, I think seems to be quite compelling. But, you know, I'm not a juror. I don't know what is going to happen at the end of the day. All I can say, I just hope he gets convicted of something. I think the evidence seems quite clear. And I think the case so far of what has been presented, we haven't seen the defense present their case, but the case so far of the prosecution seems quite strong, with his supervisors, with people who train, said this isn't training. He went above and beyond what would be done, that I would expect a conviction, but then I have been surprised before. So let's see what happens. I can only say that without a doubt, there would be immense pain, anxiety, frustration of the Black population. And I'll be honest with you, a lot of white young people, I teach a lot of white young people, a lot of white young people are very into this as well. And that's one of the things that's new about the protests recently is the number of whites engaged as well. So there would be an explosion in this country if in fact this man is found not guilty in the face of just even the evidence that has been presented to date. So I hope that isn't the case. But what I would say, from the studies I mentioned before, there is a lot of evidence indicating that stress and acute stress linked to one's race makes all of us feel vulnerable, because it could be me, it could be my father, it could be my child, it could be my brother, and that would leads to poorer mental health and poorer physical health. There are more studies of the mental health effects than the physical health effects, but clearly there's a link between the two. And I think if that man is found not guilty, it's not going to be pretty.
Dr. McCullough, you had a question concerning forgiveness that you wanted to ask?
Yeah, this is a little bit off the topic slightly, but it's related to it anyhow. I know you've been here a long time, and thank you for, we went over our time, but you had an article some years ago about sleep and health and the how it correlates with forgiveness. And does that apply to a group like you just discussed? Like something like George Floyd happened in a neighborhood, and if the overall mindset of the group is very religious and more willing to forgive, do they suffer less stress? Do they suffer better health? And the second, what is the definition of forgiveness? We argued about that definition of forgiveness. Is it can you can't really forgive someone, as we were told, unless you actually put them give them full restitution. In other words, if somebody harms you and steals from you, or you lend somebody money and they wouldn't pay you back, now they come back to you, you've forgiven them, but now they're asking you for money again. Do you give them money again? That means that's a full restitution. So how is that definition of forgiveness used when you do the study?
So it's a good question. Really more involved than I can fully answer here, but let me try to answer quickly. Yes, I have actually done studies. There was Laurent Toussaint was the first author of that paper. He was a postdoc with me more than 15 years ago, and his whole career is on forgiveness. I had just completed the first national study of forgiveness and health, funded by the Templeton Foundation. So yes, forgiveness, we have a book out, an edited volume on forgiveness and health, and so on. So forgiveness has been one aspect of religious involvement I've studied. So generally speaking, what we find is, yes, people who forgive others have better health. There's a relationship between holding on to grudges. And I would say in terms of the definitions we use, it's not necessarily restitution. It is letting go of the grudge, letting go of the hurt. It doesn't mean you're going to give that much rent, loan that person money again, because that may not be wise. If that person didn't pay you back and has a problem, you may be enabling that person in some habit that's problematic. But it is really letting go of your anger, letting go of the hostility and rage you feel against that person, and forgiving them. It doesn't mean that this person is now your best friend, but it's just not letting that pain continue to eat you away. In fact, even at Florida Hospital, there was a classic study done years ago that showed you took patients with hypertension, brought them in, and I told them 6 or 8 week, one night a week forgiveness therapy program, kind of a seminar, led to reductions in their blood pressure and better health. And the evidence on forgiveness and health is very good, that people who forgive do better in terms of physical and mental health. But it's really about letting go of that animosity and wanting to take revenge on that person. And it's not necessarily, I would say, a full restitution per se, but it's not letting that drive you and eat out at you. So it's letting go of that resentment and anger.
Dr. Williams, we could spend the rest of the afternoon going on. It's now 4 o'clock. We've gone 2.5 hours. I'm going to ask you, what would be your last word to the viewers who are watching, those who are listening? What would be your last word to us this afternoon?
I would say thank you for making time and staying this long. That's the first thing I would say. But really, the second thing I would say is I think all of us, and we're all struggling, none of us is perfect, but all of us need to have a new vision of why God has placed us here and how he wants to use us to make a difference in the lives of others. And if there's nothing else you get from the presentation today, is that we are living in a society with great human need, where there are people struggling, there are people suffering. And every blessing we have from God, God has given it to us to make a blessing to others. Let us let it overflow into the lives of others. And the more, the Bible promises, the more we give, the more he'll give to us. So the more we share the blessings we have received, the more he can use us as a channel of blessing to others. And I wish everyone can take up that mantle, and God will give us the grace. He will give us the strength. He will open the doors. Let's be willing, but let's study. Read Isaiah 58, read Ministry of Healing. You can get it online for free. Ministry of Healing, you can get it online for free. You know, I mean, there are websites that have it, the full text there. You can get it online for free. And let's do the work that God has called us to do. Thank you so much for the invitation and for the time to spend with you.
Dr. Williams, on behalf of the men of Friends Talking, I'd like to take the opportunity of thanking you for spending some quality time and giving us information that is quality information for us to digest. You have fed us. You have given us too much, really, for us to digest this afternoon. It will take us months to digest all that you have said to us. Please, you are more than welcome to come back again and to share with us new insights, new developments in your studies, and we look forward to having you again. Again, on behalf of the men of Friends Talking, thank you for taking the time to be with us today.
Very welcome.
Thank you, sir. Next week, we're going to be having Sebastian, who will be our host. And for our wider audience, for those who joined late, normally this is a men's only forum, but because of the quality of information today, we decided to open it up to everyone. Next week, we will return to our original format where we'll have Sebastian, who will be our host. And Sebastian, are you able to give us some information about our presenter for next week? Sebastian, are you there? All right, we will get the information as time goes on during the course of the week. If there are any men out there who is interested in joining, well, not joining, but becoming a part of us, please, you can put the information in the chat and we will get in contact with you and welcome you to the Fellowship of Friends Talking. Gentlemen, have a good rest of the afternoon. Before we go, we're going to close with prayer. Dr. McCallum?
Again, I want to thank you, Dr. Williams. Again, powerful, power-packed. Shall we bow our heads? Dear Heavenly Father, we thank you for allowing us to sit here and listen to this information that we can utilize to further spread your gospel, your message. We're thankful for my friend, Dr. David Williams, and for what you've allowed him to accomplish, and for putting him in a position so that he can disseminate this information to all of us, that we can develop better health practices and also be able to reach our fellow man and help them. Thank you for Sabbath. Thank you for today. Bless all the families connected here. All these things we ask in thy name. Amen.
Amen. Gentlemen, have a good rest of the Sabbath and have a wonderful week. God bless.
All right. Take good care.
Thank you, Doctor.